So the first speaker is Dr. Shubhojit Chakravarti. Is he here? Dr. Vijay Kumar Maurya. Anubhuti Bhargav. Dr. Vinod Kumar. Okay, Dr.
Vinod Kumar, you may present.
So he'll be speaking on post-cataract surgery and ophthalmitis, presenting as retinal vasculitis. Yes, please start.
Good evening, everyone. So I'll be presenting a series of patients where they initially presented as vasculitis in a post-operative period and later turned out to be endophthalmitis. So a brief introduction where we know this is a dreaded complication where the incidence is, even though the incidence is very less, but nobody wants to see this type of complication, and the incidence is around 0.1% in post-cataract surgery and 1 in 5,000 injection post-intravitreal injection. They usually present with profound sudden loss of vision, conjunctival and anterior segment inflammation, hypopyon, glaucoma. On the day of presentation, anywhere from day 1 to 6 weeks, like in case of fulminant endophthalmitis and chronic endophthalmitis, it is 6 weeks. And the average duration is 6 to 9 days. And sometimes we diagnose when they are not responding to topical medications or oral medications. So these are the various kind of presentations. One thing is that we should get a B-scan done whenever there is a suspicion. The most common organism is Staphylococcus aureus, Coagul is negative, Streptococcus, some gram-negative species. The most practice we routinely follow is give an intravitreal injection and wait for 24 hours to see the response. If there is a response, we repeat it after another 24 hours, or we can plan a vitrectomy if this is not responding, or early vitrectomy is also a better option. So in all our cases, patients, where 3 cases we have noted, in 3 patients we have noted these kind of symptoms. They were all precautions were taken. Intracameral moxifloxacin was used, adequate betadine contact time, patching time of 4 to 6 hours, and in post-operative period, patient was given moxifloxacin and dexamethasone. So this was the first case. Patient was operated for mature cataract. So pre-operatively there was no fundus examination, that was not possible. As you can see, there is a dense, patient came with a history of floaters and mild falling vision. Patient had vision of 6/12. As you can see, there is a sheathing around the inferior vessels with white-centered hemorrhages and disc edema. So since it was a mature cataract, and in day 1 and day 2 there was significant corneal edema. Once the corneal edema resolved, we saw this patient on day 4. Initially we thought it as a missed vasculitis, looking at the OCT picture and also vessel involvement. But the next day the patient presented with full-blown end-off. So patient was taken to immediate vitrectomy. The one thing I wanted to show in vitrectomy is this presence of sclerotic vessels in the periphery. But luckily patient did very well. After 2 weeks, all those sheathing and all those kind of hemorrhages resolved, and patient did well. And within a span of 4 weeks, we saw another patient in post-operative period at day 5. Patient presented with floaters and mild fallen vision, and we could get a FA, and we could make out the vessels involvement. Since we had already had an experience with a previous case, this straight away, this is the third case. This patient also came with a history of floaters and hemorrhages and kind of a vasculitis picture. So these are the 3 patients. The most common presentation is either mild falling vision or floaters or mild redness. Other than that, patients were mostly having 6/12 or 6/18 vision. So in the last 2 cases, we directly treated them as a post-operative endophthalmitis, gave vancomycin, dexa, and one of the patient needed vitrectomy also after 2 days. The sample we recovered Staphylococcus epidermis, which was moxi-resistant, vanco-sensitive. All patients recovered good vision at 3 months. Vascular signs surprisingly got recovered. So we went into the literature and saw so many case reports which were documented earlier. So this was a case report where ranibizumab post-ranibizumab patient developed vasculitis, and few other case reports where they could see hypopyon in the posterior pore also, where I could also make out during vitrectomy. These are the new fresher reports, and there are reports dated back 25 years also, hemorrhagic vasculitis turned out to be endophthalmitis. So patient presenting in a post-operative period with a mild pain or very small, less drop in the vision, but if there is a floaters, this should be considered as a and patient should be worked up, thorough retinal examination should be done, and whether it is related to moxie-resistant bacteria or whether this patient, why this patient presented initially with vasculitis, we don't have any additional literature, but very good thing is that these patients are managed as the existing guidelines of endophthalmitis.
So what do you think vasculitis can occur in which form of endophthalmitis? The vessel involvement in the beginning can occur in endophthalmitis also, that too endogenous,
Yes.
not like this.
Yeah.
So this may be the first case, first initial cases. Or do you think in the post-op endophthalmitis the vascular component, because of toxins, the vasculitis has already started? Or you were the first one to detect in the early phases when media was like...
Yeah, might be that we detected early, and might be the anterior inflammation got supplied with the medications, or my anterior segment was fine and everything started with the posterior thing.
But you have detected early, that is why you could see the posterior segment.
Yeah. But whenever we do vitrectomy, otherwise also, which are detected normally, these kind of presentations will be there when we do the vitrectomy, but these patients surprisingly presented with retinal finding initially.
So what was the culture reports in the other patients? Could you correlate it to some kind of etiology?
Culture, all three patients were positive for Staphylococcus epidermis, and they were all sensitive to vancomycin.
And sometimes you may see these kind of vasculitic picture in severe post-op inflammation also. It needn't be an endophthalmitis. So how would you suggest that we differentiate the two? Very severe, some inflammatory reactions. Yes,
but
you do
since
see
the vitreous is involved and retina is involved, and in the first patient we saw on the day 2,
and they were all culture positive, so that is why it was endophthalmitis. It was an inflammatory. They all were culture proven cases of endophthalmitis. Just a comment, in your first slide you said the ideal presentation of endophthalmitis is this. There's no ideal presentation, it should be the usual presentation.
Thank you.
Okay.
Next, डॉक्टर ऋतु राज तो आए. नेक्स्ट चलो कोई नहीं. अनुष्का आप आ जाइए. वो हॉल ढूंढ रहे होंगे ऋतु राज.
Speaking on microbiological profile and visual outcome in post-operative endophthalmitis in tertiary care hospital in Northern India. So infectious endophthalmitis following cataract surgery still is a devastating condition. Despite major improvement in surgical technique in the last decade, most series report on an incidence rate ranging from 0.05 to 0.4% in different studies worldwide. Most cases are caused by microorganisms from the conjunctiva and the eyelid. They might be secondary to surgery or to trauma. So this is a retrospective study of post-operative endophthalmitis from August 2023 to March 2024 in 100 patients in a tertiary hospital of Northern India. So any patient developing endophthalmitis within 1 year of any intraocular procedure was included in the study. According to the severity, treatment with a trial of intravitreal antibiotic injection or port vitrectomy was performed. Ocular samples were collected, which were either anterior chamber tap or vitreous biopsy, and sent for the microbiological examination. The samples were stained with gram and KOH stain and cultured on chocolate agar, blood agar, brain heart infusion broth, and seborrheic dextrose agar. The following information was assessed: the number of presumed and culture positive in the endophthalmitis cases, the source of infection, the microbiological results. So the exclusion criteria were: any patient developing endophthalmitis after 6 months of any other intraocular procedure, patient having pre-existing posterior segment pathologies, patient having systemic disorder like uncontrolled diabetes mellitus. The results were as follows: vision after 4 months, 6/60 was found in 35 patients, 6/36 was recorded in 48 number of patients, 6/24 in 12, finger count in 3 and hand movement was present in 2 patients. The microbial distribution was as follows: the most common microorganism in our study was Micrococcus, which was found in 45 number of patients, Staphylococcus aureus in 32, Staph saprophyticus in 8, Staph epidermidis in 1, Streptococcus 2, Citrobacter 2, and no organism was found positive in 5, and Kiwish mouth was positive in 5 patients. The organism distribution is as follows. So this picture shows the patient on whom early vitrectomy was done showed better visual outcome, as it can be seen in pre-op picture 1 and 2. The patient in whom late vitrectomy was done showed lesser visual recovery after vitrectomy. The pictures as shown here are the organism found was organism Staph saprophyticus. This is the second picture is after 4 months of the surgery, after both vitrectomy and intravitreal. These are the pre-op and post-op. And poor prognosis was found in patients in whom corneal involvement was also present. So discussion as expected, most cases were secondary to a surgical procedure, that is 62% or trauma 12%. The microorganism profile in the post-operative and post-traumatic group is that present in the conjunctival flora in both and from the environment in the latter. In previous study, Staphylococcus aureus was the most common organism found, in contrary to our study in which Micrococcus was found. The limitations are time frame of the study, antibiotic susceptibility can also be assessed, and more counseling should be done in the patient who were lost to follow-up. Conclusion, aggressive treatment should be done even if we suspect reaction, and the case should be approached as it is of endophthalmitis. Early vitrectomy and intravitreal injection within 3 days from the diagnosis was the sole positive predictive factor for improved visual acuity, showing its advantages over delayed vitrectomy. Thank you.
So I just noticed that none of your patients had a visual acuity of better than 6 by 60. Is that correct? So what do you think was the reason? Were they taken up late for vitrectomy? Because generally, if we've done an early vitrectomy, we sometimes get...
Patients were taken late for the vitrectomy because ours is a tertiary care hospital. Most of the patients that we get are mainly referred from other hospitals, and they are very low socioeconomic status patients. So when they appear to us, they come 15 to 20 days later.
Okay. And you did not talk about the KOH mounts that, since it was a microbiological profile you were studying, did you also study the type of fungus? That would also have been worthwhile.
KOH mount was found positive in 5.
No, which fungus? Aspergillus or Candida? So you could have mentioned that as well. That would also have been very relevant to the study. Yes.
Okay. Next is Dr. Rituraj.
Greetings everyone. My free paper today deals with the effect of intravitreal ranibizumab administered 3 to 30 days prior to vitrectomy in case of diabetic vitreous hemorrhage. We don't have any no financial concerns regarding this. So it was basically the indication particularly was significant diabetic vitreous hemorrhage patients where there was no visibility of fundus who had received intravitreal ranibizumab 3 to 30 days prior to vitrectomy. Pre-injection B-scan was showing no traction on the retina, and all the cases had undergone vitrectomy with endolaser with or without phacoemulsification, irrespective of the grade of cataract present at the time of the presentation. The exclusion criteria were patient on anticoagulants or antiplatelets, other ocular comorbidity factors like uveitis, glaucoma, pre-existing neuropathy, preoperative or post-operative retinal detachment, follow-up less than 3 months, and post-operative siliconoid tamponade. All the cases who had certain contraindication for anti-VEGFs, particularly like pregnancy or lactating mothers or recent thromboembolic events, were also excluded. So there were 40 eyes of patients with significant diabetic vitreous hemorrhage were analyzed. All the cases underwent complete ophthalmic examination, B-scan examination to particularly look for any traction on the retina. And when there was no traction, then intravitreal ranibizumab was given prior to vitrectomy. 15 of these cases showed resolution. 25 cases underwent 25-gauge standard 3-port Pastana vitrectomy. Particularly intraoperative endodiathermy applications, retinal break formations during PVD induction was noted. And post-operative complete ophthalmic examination with OCT disc and macula was performed at the standard follow-ups as mentioned here. Post-operative rebleed rates were noted, and out of the 25 cases, 2 cases were lost to follow-up and 23 cases were then analyzed. These are the patient demographic indicators. I would like to draw your attention on the intraoperative endodiathermy applications, which were 5. Retinal break formation were 2, and rebleed was seen in one of the cases. Average preoperative vision was 100 mm close to face. and vision improved from hand movement close to base to 0.254. Average post-op RNFL thickness was 90.71 microns. This is a video. It is a representational video of that particular one of the cases, a pseudophakic patient which having received intravitreal ranibizumab prior to vitrectomy, having pre-macular hemorrhage. After approaching the vitreous core vitrectomy was performed, and then vitreous was stained with triamcinolone. With the cutter section, the vitreous was tried to pull up. I tried to pull it off the vitreous from the optic disc, not possible. So I used the forceps, and this is at this line particularly. There is a chance that there can be aversion of the disc blood vessels or the NVEs and lead to bleed, or there can be retinal break formation. So these are certain pre-op and post-op photographs, pre-op B-scan and post-op fundus photograph showing good results. Accompanying, you can also see the post-op OCT optic nerve head as well. This is one more case where we encountered a rebleed, particularly who had to undergo air blood exchange with good post-operative results. So preoperative anti-VEGF has been proven now as a useful adjunct prior to vitrectomy. It reduces surgical time, lowers rates of intraoperative complication, and reduces rebleed rates. However, there is a tendency to use these anti-VEGF in advanced PDR cases because, and also one of the main concern while using anti-VEGF is progression of retinal traction. So in our case analysis, we used the anti-VEGF, that is ranibizumab, for diabetic DVH cases where there was no traction on the retina. So why IVR? Because the posterior vitreous detachment induction is an important step of vitrectomy. There is avulsion of NVD or NV while we are performing PVD induction, and in such situations endodiathermy application or increased infusion pressure is applied. Both of these maneuvers are detrimental to the effect of the retina, and IVR helps in resolution of NVDs or NVs when administered prior to vitrectomy. In our retrospective analysis, as I already underlined, 5 cases required endodiathermy applications. 2 of them had retinal breaks, and 1 case had rebleed. In our case analysis, we were able to achieve better intraoperative hemostasis. Better intraoperative hemostasis means less frequent endodiathermy applications and reduced infusion pressure. And both of them particularly helps in preserving the optic retinal nerve fiber layer as has been reflected in our analysis. Better intraoperative analysis also helps in better visualization, which will help in better completion of a PRP, which reflects in the reduced rebleed rates, which are found to be less as compared to the reported post-vitrectomy rate. So use of IVR prior to vitrectomy can help in achieving intraoperative hemostasis and can be a useful adjunct in the management of diabetic vitreous hemorrhage. Thank you for your kind attention. These are my references.
Thank you. 3 to 30 days. What is the usual you will recommend or recommend it?
The literature
These are the plain vitreous hemorrhage.
These are the plain vitreous.
No traction.
No traction. So usually when I went through the literature, they say the ideal time is almost around 10 days where they can balance out the fibrous contraction, at the same time the positive effect of resolution of the neovascularization. So they say around 10 days. That is the ideal. But what we particularly, the group what we looked into was 3 to 30 days, because when the patient came to us, particularly we gave them an option of going for an injection first, and then we told them that if it does not resolve, then we'll proceed for.
These may not be. These may be the mild vitreous hemorrhage, not media complete haze in which you cannot visualize.
There was the disc was not particularly
But certain area you could see.
Yes,
because
certain area, yes. Because
in what percentage you have seen tractional detachment after 30 days or around 25 30 days?
No, we have not seen, because that was the RDs particularly were excluded. And one more important thing was 15 of the 40 cases showed resolution of vitreous hemorrhage after
that
action.
That is the. Okay. Next, Dr. Ankur.
So I'm going to talk about anti-aggregator hyalodoroscopy, a non-invasive treatment for anemic retinopathy with premacular hemorrhage. So as we all know, anemic retinopathy is usually seen in patients with hemoglobin below 6 gram per dl, especially when the patient has coexisting thrombocytopenia. Anemic retinopathy usually presents with superficial flares of hemorrhages, dot point hemorrhages, subhyaloid hemorrhages, and even with vitreous hemorrhages. Subhyaloid hemorrhages less than 2 inches diameter tend to resolve spontaneously, so does not require any treatment. However, when there are larger subhyaloid hemorrhages, that is more than 2 to 3 disc diameter, it usually requires treatment, as prolonged presence of premacular bleed can lead to toxic damage due to extended contact with hemosiderin, thereby leading to permanent damage of the retina and thereby leading to permanent visual impairment or disability. Treatment options range from pneumatic displacement of the subhyaloid bead with the help of gas and intravitreal TPA. PPV is also done if there is which is there for quite long. And however, there is a very simple office non-invasive procedure that is known as Nd:YAG laser hyalurotomy. And also there is another option to that, there is green laser hyalurotomy. So the purpose of the study was to evaluate the safety and efficacy of Nd:YAG laser hyalurotomy for premacular hemorrhage in anemic retinopathy. This was a prospective international study carried out at a tertiary care center in northern India, that is in GTP Hospital, from June 2023 to September 2023. 12 patients with acute vision loss secondary to premacular hemorrhage larger than 2 disc diameter attributable to anemic retinopathy were included. Outcome measures were successful hyalurotomy, change in the visual acuity, and adverse event like macular hemorrhage, macular holes, retinal holes or RD, because we know that YAG laser has a photoreceptive effect. Exclusion criteria were presence of any media opacity, old pre-macular bleed which were not amenable for the treatment with the Nd:YAG laser hyalurotomy when there was an ERM in these patients, and patient not consenting for study. So all recluded patient underwent complete ophthalmic examination that included best corrected visual acuity, serial color fundus photography, and SD-OCT at baseline, post procedure at 1 week, at 4 week, and at 8 week. All laser treatments were performed under mydriasis with topical anesthesia and using Goldman 3-mirror contact lens. Q-Sys Nd:YAG laser, that is NIDEF YCA 1800, was operated at an energy level between 5 to 10 millijoules on a single burst mode. 1 millijoule increment was made when we could not achieve the successful hyalurotomy, and the hyalurotomy that were made were 1 to 2 openings in the anterior hyaloid at the closest to the inferior edge of the hemorrhage. So once there was successful visualization of the gush of blood that was coming down from this bleed, this marked the completion of the procedure. Patient in which the hyaloid could not be breached, even with 2 successive spots of 10 millijoules, were treated as treatment failure. Patient with treatment failure were recorded and were treated with PPV. Any adverse event during the follow-up was also recorded. So these are the case examples. Case example 1 was an acute patient who came to us within 3 days and has a preoperative subhyaloid bleed, as you can see in the image 1. The image 2 shows that although after 1 week after the YAG laser hyalurotomy, we can see the space and the opening in the hyaloid, but the pre-macular space hasn't collapsed. And at 4 weeks, the vision recovered to 6/6 with the collapse of the hyaloid phase and absolutely normal retina. In another patient, this was the patient that presented to us at 3.5 weeks and had a vision loss. Because this patient presented to us a bit late, if you try to look at the fovea, you will see a brownish appearance. So even if after doing Nd:YAG laser hyalurotomy, the patient never achieved good vision, because this is what I was talking about. If you leave the blood for longer time, this will lead to toxic retinopathy, and you can see the OCT below. So this is the complete profile of the patients. So my results are that the mean time of presentation in our study was 5.2 days. 11 out of 12 patients could achieve successful result. There were no adverse event. The mean energy required to 6.8 millijoules, and all patients except one achieved good visual acuity, that is 6/6. So in conclusion, I would like to say the laser hyalurotomy or Q-Sys laser is safe, non-invasive, outpatient method advised for early presentation of subhyaloid hemorrhage. However, case with delayed presentation can also undergo this procedure with caution, because they tend to require more energy, and they are the patients which can tend to undergo treatment failure. Good clinical assessment, precise positioning of the laser spots, and using lower energy are the key for successful procedure. Thank you.
Thank you, doctor.
Yeah, nice. You showed some very good pictures. Did you have an inclusion criteria about the duration of the hemorrhage, or no, you just took up all
Ma'am,
hemorrhage?
we did not take any cases which were more than 4 weeks.
Did you show that in your inclusion?
Ma'am, that was acute. When I mentioned acute, this is what it is.
Okay.
So because the exclusion criteria was the chronic cases which were not amenable for the laser. So more than 4 weeks will tend to have an ERM or thickened hyaloid. So they are not going to respond to. You keep on hitting them with the larger energy, it is not going to affect. So that was the exclusion criteria, the chronic cases.
And there was one case you said which had a poor visual outcome. So was that due to the vitreous hemorrhage that broke through?
So that was the one patient that in our city, this was the most, this was the patient that presented the most later part of the 3.5 weeks. So he, when presented to us, had certain changes in the fovea. So if you see in that image, they had those oranges appearance in the fovea. So this is what I want to show, that if you don't treat them in time with a small office procedure, they can lead to permanent visual disability. So if it is not amenable to de-angle the halodotomy, do it.
Also, the vision may not immediately improve. When you hemorrhage, when you do that halodotomy, the hemorrhage comes into the vitreous, and then sometimes that hemorrhage may take longer to resolve. So that's why
Absolutely, ma'am, and that's why we assess the patient till 8 weeks.
Yes.
So 2 months. So the final visual acuity
Yeah,
happens in 2
that's
weeks.
yes. Did you mention your final? Okay.
Thank you, Dr. Ankur.
Dr. Utkarsh.
Hello. स्लाइड देखिए डॉक्टर
Good evening everyone. Topic for my paper is Ozil phacoemulsification handpiece versus phacofragmentome in a management of drop lens fragments. Introduction. Dislodgement of lens fragments into the vitreous cavity occurs in 0.1 to 1.5% of the cataract cases. The Ozil handpiece using torsional movement reduces repulsive forces compared to the traditional phacofrag, which uses axial ultrasonic energy. This is the first RCT comparing the Ozil handpiece efficacy to the traditional phacofrag for managing drop lenses. There is no financial disclosure, though no conflict or interest. Aim of the study is to determine the efficacy of Ozil phacoemulsification handpiece versus the traditional phacofrag in handling posterior displayed lens fragment during the cataract surgery. My primary objective was to estimate the effectiveness of Ozil handpiece in reducing surgical duration and minimize intraoperative complication, especially the displacement of lens fragment onto the retinal surface compared to the traditional phacofrag. My secondary objectives were to estimate post-operative best corrected visual acuity (BCVA) and compare the outcomes between the patients treated with Ozil handpiece and those treated with phacofrag. To estimate the incidence of post-surgical CME, the patient who underwent surgical via both surgical methods, and to determine the safety of Ozil handpiece and the phacofrag, the surgical sites were evaluated post-operatively with a focus on presence of scleral burns or other related complications. Material and method. It is a prospective interventional randomized controlled trial study done in a tertiary care center in eastern India with a duration of 6 months. This is my CTRI number. A study enrollment inclusion criteria. We enrolled patient who experienced nuclear dislocation during cataract surgery. Exclusion criteria was patient with retinal detachment or endophthalmitis. Thorough ocular examination was conducted before the surgery. Treatment of increased intraocular pressure, uveitis or corneal edema was done so that best optimal visualization was done during the surgery. Lens criteria from grade 2 to 4 are included in the study. Nucleus drop duration was recorded and informed consent was taken. Sample size of the study was 40. We employed block randomization with group 1 containing 20 patients undergoing traditional phacofrag surgery and group 2 containing 20 patients undergoing surgery by Ozil handpiece. The surgical overview. The surgery was done under local periverbal anesthesia with 10 ml of 2% lignocaine and 0.5% bupivacaine. Pre-anesthetic evaluation was done by anesthesiologist. Initial procedure was done by 25 gauge vitrectomy to clear vitreous around the dislocated lens fragments. Posterior vitreous detachment was performed. Sclerotomy was performed at superior temporal and superior nasal quadrant based on the eye 3.5 mm posterior to the limbus with 20 gauge MVR blade. Additional vitrectomy at the port site to ensure a clear path was done. Group specific techniques. Group 1 underwent traditional phacofrag surgery, whereas the group 2 underwent surgery through Ozil handpiece. Infusion pipe of the Ozil handpiece was disconnected and was sealed with needle cover. Sleeveless Ozil handpiece was inserted through the sclerotomy and phacoemulsification was performed using torsional movement. Vacuum pressure of 250 mm Hg was used, aspiration 30, torsional amplitude 100% and phaco power was adjusted based on the lens density. Post-operatively, peripheral retina was examined for etiogenic damage. Sclerotomy sites were closed and additional vitrectomy was done if needed. No use of PFCL was there. Post-operative monitoring and prescription of topical steroids and anti-glaucoma drugs were there. My demography, out of 40 patients, 22 patients were male and 18 were female. In group 1, mean age was 61 and in group 2 mean age was 63.56. These are the preoperative characteristics. As you can see, during the surgical duration in group 1, the duration is 152 seconds, and in group 2 is 110 seconds, and the p value is less than 0.001, which is significant. In group 1, there is mean fall frequency was 7, and in group 2, using the Ozil handpiece, it is only 3, which is also significant. Post-operative characteristics, in both the group, the BCVA was almost within the equal limits, and and also macular edema was also same in both the cases. So the key result is mean surgical duration was significantly shorter with the Ozil handpiece compared to the traditional phaco-frag. The Ozil handpiece employs a rotational cutting technique which minimizes lens fragment displacement and reduces chances of milking phenomenon. Despite the shorter length of the Ozil tip, there was no significant issue reaching the posterior segment, though challenges may arise in high axial myopes. No significant difference in the incidence of cystoid macular edema between both the surgeries. Limitation of my study is that it is conducted in a single tertiary care center, which may limit the generalizability, and the study did not address the availability of Ozil handpiece in different healthcare settings or a cost to benefit analysis was there. Conclusion: Ozil handpiece significantly enhances surgical efficacy and safety in nucleus stop surgeries. Its integration into existing phaco-frag systems could represent a major advances in the ophthalmic surgical tools, ensuring the improved patient care. Thank you. These are the references.
So you have used the phaco machine,
Yes, sir.
phaco machine can be used. So you have done before using phaco,
Yes, sir.
you have done complete vitrectomy.
Yes, sir. After PPB and then we for the
No, before taking out the nucleus with whatever method, you have done the complete vitrectomy.
Yes, sir.
Okay. So you have also graded the thing. This study is between what to 40 drop nucleus. So you have graded different type of size of nucleus, half, 1/2, full
No,
nucleus.
sir. Only grading of the nucleus was done.
Only?
Logs grading of the nucleus was done.
So that means if it is a 1/4, then less energy. If full, more energy.
That was not done.
Acha, koi baat.
Because see, the falling down is more if the piece is big or if it's a full nucleus. If they're smaller pieces, then they're not going to fall down as it is, even with the fragmentome. So your what was your main advantage that you mentioned was that it holds the pieces better
It
and
holds the
doesn't.
pieces longer and more
Yes.
effectively.
So it would have been better if you'd taken like the full nucleus, because that's what tends to fall down. Smaller pieces as it is don't, they just come in very easily with the fragmentome as well.
Yes.
So that would have been a better study if you had told, or at least you would have divided it into, the size of the fragment as I said. And what is the gauge of the Ozil handpiece?
To the 23 gauge port it goes easily.
Through 23 gauge. Okay. Yeah, so
But for
we do
phaco
use,
frag you do?
and for
What's
phaco-frag?
phaco frag? You have used the 23 only.
23 only.
No.
The phaco frag, chalo, theek hai, thank you.
So yes, the only limitation would be in a high myope where the tip is small. The tip of the phaco handpiece is much smaller than the fragmentome.
And other limitation can
handpiece.
be if the machine is not available at that center, we
Right.
cannot use that.
Exactly. So once, if your fragmentome is not available, you can use the phaco
Yes.
tip, and we've also done it before in the past when our frag was not working. Okay, thank you.
Thank you.
To present. Good afternoon, everyone. I will be presenting on intraocular inflammation following intravitreal faricimab. Faricimab is an FDA-approved novel bispecific monoclonal antibody that targets both VEGF-A and angiopoietin-2 and has been approved for wet AMD, DME, and RVO. And ours was a retrospective case series at our center carried out over a period of 8 months. All patients underwent thorough pre-op and post-op post-injection evaluation at the given days. In our series of 26 eyes with 24 patients, we came across with a maximum number of injections of 2, we came across 3 incidents of IOI following injection faricimab. This is to compare with brolucizumab at our center, where we have come across 3 out of 42 eyes. 3 incidents of IOI following injection brolucizumab. So coming to the cases of faricimab, 73-year-old male with bilateral IPCV who had received past 10 intravitreal injections in the right eye and showed non-response, was switched to faricimab. On 7th day post IVT faricimab, with cells 1 plus were noted, and he responded well to treatment with topical prednisolone. There was no evidence of vasculitis or vascular occlusion. Similarly, this was a case of a 68-year-old lady with wet AMD in the left eye and 4 injections of ranibizumab and 12 ILIA in the past, and a history of mild vitritis following 1 injection of brolucizumab in the past. She also presented similarly with cells 1 plus on day 7 post-injection faricimab and did not show any vasculitis and responded well to topical steroid therapy. The third case was that of a lady with wet AMD who presented on day 7 post-faricimab with multiple pigmented KPs and no evidence of vasculitis or vascular occlusion. She also responded well to topical steroid therapy. She happened to be suffering from osteoarthritis as well. Reports of faricimab have been uncommon. Reports of IOI after faricimab have been uncommon but statistically higher than those of the aflibercept group, not as high as those of the pegcetacoplan or the brolucizumab group. This is a series of 71 eyes in which one patient showed IOI in the form of mild vitritis similar to our cases. There have been reports of severe IOI as well following faricimab, such as this series of 3 patients, one of whom required a therapeutic vitrectomy on the first day following presentation. There have been reports of bilateral occlusive vasculitis, 2 cases of granulomatous uveitis, and also another case of vasculitis following intravitreal faricimab. So sterile IOI can present in the form of a severe acute onset inflammation, often mimicking an infectious endophthalmitis, or a delayed onset inflammation. The latter has been associated with intravitreal brolucizumab and pegcetacoplan in the form of an occlusive branch arteritis. A history of uveitis, use of prostaglandins, and a history of diabetes and AMD, and the presence of treatment boosted anti-drug antibodies makes a patient more prone to IOI. The Fc region of the anti-VEGF molecule itself is a very immunogenic factor and it is absent in the ranibizumab molecule. Faricimab has a modified Fc region which prevents its binding to Fc gamma receptors and lowers the incidence of IOI. Bacterial endotoxins, impurities, proteins, syringe agitation, freeze-thawing processes, shipping and handling may all lead to IOI. The mainstay of treatment is steroid therapy via different routes. In severe cases, even a pars plana vitrectomy may be considered. This to compare with IOI following injection brolucizumab, there was this meta-analysis of 31 reports with 46 eyes, average age 75.9, and most of them were female. And IOI occurred at a median of 37 days following treatment with an average of 2 injections. To summarize, at our center, following IVT faricimab, we have come across 2 cases with mild vitritis within 7 days post-injection and 1 patient with anterior uveitis on day 1 post-injection. None of them had vasculitis or occlusion and they responded well to treatment with steroid therapy. 1 lady had a history of IOI in the past following single intravitreal brolucizumab. Medication-associated uveitis is a rare side effect of drug administration. Early diagnosis and treatment after disease onset prevents severe visual impairment. There have been few reports for IOI following faricimab, and steroid therapy forms the mainstay of treatment. Thank you.
So did any of these patients also have a previous history of uveitis, or did you try to exclude that because that's a very important factor?
There was no history of uveitis, just the 1 incident of mild vitritis following injection brolucizumab. That was also on day 7. She was not, and after that we switched her back to ILIA because faricimab wasn't available yet. But then we thought of still going ahead with the new molecule as soon as it was available because there was no response to anything.
And the patient with the rheumatoid arthritis, once she developed this reaction, what was the injection that you subsequently gave, and did she get a reaction with that?
So ma'am, that was osteoarthritis. She was RA factor negative and anti-CCP negative. It was severe osteoarthritis, although the picture looks similar.
Yeah.
So
the pictures you showed appear to be rheumatoid arthritis.
Yes, ma'am.
So I think osteoarthritis has no correlation.
No.
Osteoarthritis would be a very common finding
Yes.
in this age group.
Yes, no.
So I don't think that needed have to have been
Yes, we were
mentioned.
confused initially when we saw the patient, so we called for reports. Even we
Or
thought
maybe
it was
she was a rheumatoid negative rheumatoid,
seronegative.
yeah,
Yes, ma'am.
seronegative
Yes,
rheumatoid
ma'am.
arthritis. That could be.
Yes, ma'am.
When you detected the intraocular inflammation,
Sir,
at what duration?
day 7 for day 1 for the KPs for the third case and day 7 for both the mild vitritis cases.
So what is your protocol after anti-VEGF to see the patient after second day, third day, fourth day?
So we usually see on day 1 and day 30 for other agents, but since this was a new molecule, we wanted to be on our toes and we checked on day 1 as well as day 7, 15, 30 and 45 and 90.
So was the patient also symptomatic? Did the patient complain of pain or blurriness? Or
Only the third case, the one with the KPs, otherwise the ones with the big cells did not.
Okay,
Yes, ma'am.
thank you.
Thank you. Thank you.
Thank you.
Thank you for this opportunity. I would like to present our study, which was on comparison of choroidal thickness in preeclamptic, healthy pregnant and non-pregnant females by optical coherence tomography. So preeclampsia is a multifactorial and multisystemic disorder occurring in approximately 5 to 10% of pregnant women worldwide. It causes various organ dysfunctions including the visual system. High vascularity with poor autoregulatory mechanism makes choroid particularly sensitive to hemodynamic alterations in preeclampsia. Thus, assessing the choroidal thickness may be used as a predictive marker in preeclampsia. A very few prospective comparative studies are available on choroidal thickness in preeclamptic women, and it is very limited by conflicting results and very small sample size. So the purpose of our study was to measure and compare choroidal thickness in preeclamptic patients, healthy pregnant women, and age-matched healthy non-pregnant women, and also to evaluate any correlation between the subfoveal choroidal thickness and the mean arterial pressure in preeclamptic patients. So we had recruited 30 subjects in each group, that is 30 healthy pregnant women, 30 preeclampsia patients and 30 age-matched healthy non-pregnant females. And it was a hospital-based comparative cross-sectional study and the duration was 12 months. Our inclusion criteria were women within the reproductive age, that is 20 to 40 years, and with less than 4 childbirths, willing to provide consent, and with BCVA of 6/9 or better, and the OCT images with signal strength of more than 7/10. Any ocular or systemic pathology were excluded. So detailed ocular examination was done, and measurement of choroidal thickness of both eyes by spectral domain OCT in the enhanced depth imaging mode was done, and measurement of mean arterial pressure. In lab investigation, specifically as appropriate, urine protein was done in the preeclampsia group. So this is here the representative image of each group. This A is the preeclampsia group, B is the healthy pregnant group, and C is the healthy non-pregnant women. So here, through manual caliper, we measured the subfoveal thickness, 1500 microns nasally and 1500 microns temporally for the each group. Then we did comparison of the obstetric ocular systemic parameters and the comparison of choroidal thickness between the 3 groups. This was done as subfoveal choroidal thickness, the nasal, the temporal and the average. So the summary of our results were as follows. There was no significant difference in terms of IOP, central corneal thickness, axial length between the 3 groups, hence all the 3 groups were comparable. No significant difference in distribution of gestational age, various age categories, mean gestational age, gravitas status, estimated fetal weight between the healthy pregnant and the preeclampsia group. So there was a significant difference between the 3 groups in terms of mean arterial pressure and the body mass index, both being highest in the preeclampsia group. The main result was the healthy pregnant group had the highest choroidal thickness, followed by the healthy pregnant women, and the preeclampsia group had the thinnest choroid. And this difference was statistically significant for the nasal, temporal, subfoveal average choroidal thickness in both eyes, except for nasal in the right eye. The correlation of
mean arterial pressure and choroidal thickness was found to be inversely related. This correlation was statistically significant in all groups combined, but was insignificant for any single group separately. So our study showed significantly less choroidal thickness in the preeclamptic patients as compared to healthy pregnant and non-pregnant women, suggesting increased choroidal vasospasm in preeclampsia. But no significant correlation was found between choroidal thickness and mean arterial pressure. So this possibly implicates that choroidal thinning in preeclampsia is governed by multifactorial choroidal vasospasm and endothelial dysfunction, and it is not solely attributed to the mean arterial pressure. So this was the literature search. Ours was the first Indian study. There were contrasting results seen. In few studies, they were showing that the preeclamptic group had thickness more than the healthy pregnant and the non-pregnant group. So the difference here was these studies included severe preeclampsia with retinopathy changes. In our cases, we excluded retinopathy changes. So any patient who had already developed retinopathy, we did not include that patient. So choroidal thickness can be used as a novel biomarker in preeclampsia patients as an adjunct to other parameters, and future prospective comparative studies with follow-up and larger sample size are required. And I'm happy to share that our studies...
So you mean to say what happens in pregnancy in choroidal blood flow? What is normally the control of blood flow in choroidal vessels?
Sir,
Normal population.
Sir, in normal population, choroidal vasculature, there is the autoregulation is poorly autoregulated. In healthy pregnant women, in literature it is seen that the choroidal vascular index increases, the blood circulation increases to all parts of the body, and because of this hemodynamic alteration, it is also reflected in the choroid. But in preeclampsia, because of the abnormal placentation, there is a systemic response, systemic vasospasm response. Because of this response is also seen in the choroid, as choroid is the window to the whole system.
So what are the clinical implications of this? How is it going to help us in our practice?
Ma'am, it can be used as a new biomarker for such patients who are at a risk of developing severe vision loss. So if any pregnant female is at a risk of preeclampsia, so using just a simple non-invasive tool, we can predict preeclampsia before she develops severe vision loss.
Thank you.
Thank you.
So our next speaker is Dr. Malika Goyal, and she'll be speaking on fibrin glue for closing retinal breaks in complex retinal detachments with silicone oil in situ.
Good evening. Bali, you saw this last year, but since then the indications have expanded and cases are different and many more. So we'll be seeing something different from last year. I hope they'll be able to run the videos. The last session they could not.
Slide.
We're trying.
Fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ. It's not advancing. Yeah. So this has fibrin glue has been used in simple retinal detachments to close breaks, but there it is used to avoid the use for any tamponading agents. It has not been reported for complex detachments with silicone oil injection. So our first case was 2 years back where we operated a complex PDR-RD, and there was a lot of SRF because of an open break in the superior mid-periphery. So we went in for resurgery for this, did membrane peeling, tried to aspirate the SRF, but the break remained open and was not amenable to laser. So at this point we injected fibrin glue over the break. The oil was already in the eye because it was an operated eye, and we found to our surprise very rapid retinal reattachment. So encouraged, and this same case after 2 years now, doing very well, no long-term complications with oil in the eye. Oil was still in the eye till recently. So we encouraged by this, we did several other cases. This is another patient with the PDR complex RD recently done. So as the membrane peeling proceeded. Finally there was a break in the superior to the macula, and this was not amenable to laser. We tried laser, so finally we injected glue over the break, as you see here. And you can see on the first post-op day, glue is seen, but the retina is attached, and within few days the glue is gone. And this is more recently the same patient doing very well. Another patient with a massive membranes over the posterior pole, PDR, and towards the end there was a break which was not amenable to laser. So again we injected the two components of the glue sequentially over the break. And you can see 1 year later the patient is still doing well, oil is still in the eye. There is no emulsification, no complications, and one-eyed patient. Okay. This was, yeah. Can you run the video please? No. Okay. So we extended this to non-diabetic retinal detachments, which is primarily macular hole retinal detachments. This is a thrice operated case of RD elsewhere. So when we saw him, we decided to put, there was no other break. So we just put glue over the macular hole after settling the detachment, and you can see the result on the 5th post-op day. And he's still doing well. A young boy, chronic RD, during surgery we found there was no break except the macular hole, which was causing the detachment. So after settling the retina, we just put glue over the macular hole, the two components, and you can see in the first week the glue is seen, not seen on the 10th day, macular hole closed, retina attached, and this is more than a year back. Oil is still in the eye. Again, sometimes the macular hole remains open, but the retina gets attached, which is very important anyway because patient gets back most of the peripheral vision at least. Like this patient, thrice operated for macular hole elsewhere, not developed a detachment because of the hole. So at the end of surgery, I had given them with the cuts, but at the end of surgery we put glue on the hole, and you can see on the first post-op day itself the retina is attached, the glue is on the macular hole, some subretinal glue. So this is a word of caution. With regard to technique, needle tip blockage is very common with glue, so check before you enter the eye that the needle is patent. Avoid excessive injection because it's transparent, so it's possible to over-inject. The blue component, which is the sealer protein, should be injected first because it's more viscous, so spillage is less. Subretinal glue in a macular location can cause atrophy and vision, adversely affect the visual outcome. Avoid excessive injection in any situation, it can keep the break open. To conclude, it is a useful adjunct in the management of complex RDs, especially when laser is not possible. And it reduces the need for post-operative positioning because the break is already closed and does not depend on the oil tamponade with no long-term complications. Thank you.
Dr. Malika, the macular holes that you showed, they were all you were doing a reoperation for the macular hole, or was there anyone like
Yeah, I think most were resurgeries. One was a very chronic RD of several years. So there it was more important to attach the retina than to think whether there would be some submacular infiltration with atrophy, because anyway they were blind.
So in macular hole associated RDs, we don't always require to plug that hole because the retina attaches as it is. So why did you think of putting the glue there?
Sometimes it may not attach, especially these are repeat cases. They have already failed.
So they were all repeat cases?
Almost all except the one chronic case.
Okay.
So they had already failed a few times. So obviously I thought it will fail again.
Any difficulty in under silicone oil putting glue?
That was only one case where we did it with where the oil was already there, and no, I had no difficulty at all. Because I think it is still heavier than oil. Oil is still lighter, so it still goes nicely over the break.
So I noticed that you put the...
You must be infusing silicone oil when you are doing under silicone oil, no?
No, oil is injected 5 minutes after the glue has been put. Once you put the glue, you wait 5 minutes so that there is no turbulence, and then we start oil injection. That is the last step.
Okay, after doing the surgery.
Yes. First the retinal surface has to be completely dry, then we put glue, wait 5 minutes without any manipulations, and then inject oil.
So I noticed that you mentioned that you drop the glue right on the break itself.
Yes.
So there have been other groups who do it a different way. They wait for the coagulum to form and then they kind of fold that coagulum onto the hole. So
Not
are you
required.
aware
Why
of?
should- Yeah, I know, I heard all that.
Yeah.
But it's not required. You can just do
Because-
1 or 2 drops on each. I didn't show the videos in detail because of the time. But in each of those, just 1 drop over the break.
No, because I've heard the other LVP group actually where they fold the coagulum back. So I don't know.
Yeah, they used to do that, then now they're not doing. But also they might be doing it for macular holes.
No, just
regular
for the peripheral breaks.
No, then I think that all is not required.
And you use them for peripheral breaks as well, apart from the macular hole surgery that you mentioned. Did you use it for?
Mid-peripheral usually, mid-peripheral, because usually these are PDR cases where there is some bleeding, you are not able to laser.
Not PDR,
Not
regnatogens. Any
Not
regnatogens?
very
Because
peripheral. Because
people have started using that and they say that they do have to use oil and gas because the glue gives a very quick
Yeah,
closure of the breaks.
well, I've used it
Did you
only for
try?
complex RDs. What you're saying is
Yeah,
probably the simple
the
RDs.
simple
No,
RDs.
I'm not talking of those, and in complex RDs, for peripheral breaks, they are already closed because you have put a band as well mostly, and you've done enough work there. So I've never had to use for peripheral, never. Mid-peripheral or macular.
And have there been any ERG studies done to prove, to show the safety in the
No,
macular
it's just 2
area?
years data I have. So
No, not yours, literature.
it was never been used earlier for.
Okay, so we don't know whether how toxic it is to the
It's not been used
photoreceptors.
long term earlier at all. No.
So the
there's-
macular area, we still don't know whether it's safe for the
Because I have
photoreceptors.
seen atrophy. I have seen
Yeah.
where it has gone subretinally.
Ah, yeah.
Fortunately, that was away from macula, but I've seen track of atrophy around that. So obviously, it will cause
It does need quite a bit of caution.
So you
to
cannot
put it
use
at
it for regular macular holes, but where you're desperate to attach the retina, there you're not worried about some loss of macular photoreceptor. I lost some time because though I had given them edited videos,
Okay.
I had to edit them here.
That's okay.
Thank you so much.
Thank you.